Good morning, everyone. Welcome to Child Grand Rounds. It's my pleasure to introduce Elaine Ruiz. Elaine is a sixth-year doctoral student at the University of Rhode Island and the psychology intern for the Child and Adolescent Acute Care track here at UCLA. Her clinical interests include conducting evidence-based treatments for children, adolescents, and young adults with primary anxiety, mood, and trauma-related disorders in acute care settings. Her research focuses on the risk and protective factors of anxiety and depression across the lifespan, particularly in disadvantaged and underrepresented populations, such as first-generation Latino immigrants. Elaine is interested in the development and implementation of culturally sensitive prevention and intervention programs for anxiety and depression in Latinx young adults and families. Elaine's career goals include providing culturally sensitive, evidence-based interventions for adolescents and young adults with primary anxiety disorders in acute or intensive levels of care. Elaine has been a pleasure to supervise this year, so I am very excited to hear her talk. So I'd love to turn it over to her at this point.
Okay, I think we're good to go. Thank you so much for such a wonderful intro. Today, I'll be sharing the results of a systematic review investigating the diversity in childhood and adolescent antidepressant studies. And before I kind of get into the specifics of the systematic review, I just want to review some of the literature about childhood mental health and the use of antidepressants in this population. As many of you know, the youth mental health crisis in the United States is a public health concern, with approximately 7.7 million children between the ages of 5 and 17 meeting the criteria for at least one mental health disorder in the last year. These rapidly increasing mental health concerns are associated with a notable increase in the use of psychotropic medications in children and adolescents. Affective disorders, such as anxiety and depression, are a particular concern for among this population. Specifically, the rates of anxiety have increased by 27%, and those of depression have increased by 24% from 2016 to 2020. And approximately 5.6 million children were diagnosed with anxiety and 2.4 million with depression in 2020. Additionally, since the COVID-19 pandemic, we have seen these rates exacerbated to nearly double the rate prior to the pandemic. So it is also important to note that there are distinct differences in the incidence rates of anxiety and depression across genders. Prior to adolescence, the incidence rate of anxiety and depression are pretty similar across gender. However, the onset of anxiety and depression peaked during adolescence, and at this point, we see girls experiencing a greater risk of developing anxiety and or depression, which persists throughout the lifespan. Additionally, studies reveal that transgender and gender nonconforming youth experience anxiety and depression at higher rates compared to their cisgender peers. This increased occurrence is associated with stigma and discrimination experienced by gender minorities, as well as other factors. There are longstanding concerns regarding the underdiagnosis of anxiety and depression in youth, ethnic and racial minorities, as cultural factors that should inform diagnosis are often not considered. Some of these factors can be differences in symptom presentation across different cultural groups, as well as different levels of stigma that individuals might experience depending on beliefs in the culture about mental health. For example, research reports an elevated risk for anxiety disorders in Hispanic youth relative to non-Hispanic whites. And this indicates that, or these findings have indicated that anxiety is differentially related to parental strategies and family dynamics in specifically Hispanic individuals. Due to the identification and increased attention to childhood mental health disorders in the US, and the inability of mental health providers to meet the great demand for psychological treatment, the use of psychotropic medications in children and adolescents has been magnified. The evidence for the use of psychiatric medications in children, however, is not as well established relative to that of adult psychiatry. Prescribing to young children, as many of you know, is particularly challenging as the majority of the psychotropic prescribing is off-label. Among the commonly prescribed psychotropic medications are antidepressants, such as SSRIs and SNRIs, which are most frequently used to treat anxiety and depression in children. Antidepressants are the first line of defense when treating childhood depression and anxiety, despite the lack of consistent results, demonstrating the overall efficacy of these medications. For example, in the context of major or severe depression, a meta-analysis evaluating 34 different clinical trials, looking at the efficacy and tolerability of antidepressants in children and adolescents, found that fluoxetine was the most tolerable antidepressant and the only one that was significantly more effective than placebo. This table describes antidepressants, as you can see, primarily SSRIs and SNRIs, which have been approved by the FDA for pediatric use for GAD, MDD, OCD, and bipolar depression. However, as many of you know, prescribing antidepressants off-label is a common and accepted practice in our field, and subsequently, children may be prescribed antidepressants at younger ages and for disorders that differ from these approved by the FDA. When we think about ethnicity and race, we also want to be mindful of these differences across groups. Ethnicity and race have been associated with the metabolism and disposition of medications, as well as interactions of those medications with therapeutic targets. Research has found that genes controlling the expression of drug metabolizing enzymes, as well as the function of the brain, are highly polymorphic. And the pattern and distribution of those polymorphic genes are typically different across ethnic groups. Therefore, this impacts vulnerability to psychological disorders and drug response across racial and ethnic groups. Some findings supporting this is one study found that Chinese patients with depression had or require lower dosages of sertraline to achieve clinical efficacy compared to white patients. Another study also found a lower effect of antidepressant treatment among Black Americans compared to white Americans, which persisted despite controlling for primary predictors, such as socioeconomic and baseline clinical factors. There are also cultural differences in antidepressant utilization. Research has demonstrated differences across ethnic, racial, and gender groups regarding the utilization of antidepressants. The research indicates that people of color and other underrepresented groups typically have poorer access to mental health care, utilize their health care at a lower rate, are less likely to be prescribed and to fill prescriptions for newer antidepressants, and are less likely to receive non-pharmacological treatment relative to white Americans. In a representative sample of US adolescents, colleagues found that non-Hispanic white adolescents were more than twice as likely as Hispanic adolescents and over 5 times as likely as non-Hispanic Black adolescents to use antidepressants. The underutilization of antidepressants by diverse groups is likely associated with the underrepresentation of these groups in research studies. Research samples have historically excluded marginalized groups and people of color. A major reason for underrepresentation of minority groups in research is due to convenient sampling in psychological research, which often results in sampling of Western, educated, industrialized, rich, and democratic populations, which are often referred as weird samples. This wide underrepresentation of diverse groups in psychological research impacts the validity of psychiatric and psychological findings, and promotes inequality, health disparities, and underutilization of services across marginalized groups. In order to address these disparities and allow for critical reviewing, guidelines such as those shared by the American Psychological Association suggest reporting the characteristics of the sample as specifically as possible, highlighting characteristics that may impact the interpretation of findings. Major demographic characteristics that should be reported include age, sex, ethnicity, race, nationality, level of education, socioeconomic status, sexual orientation, and gender identity. So due to the increase in youth depression and anxiety and the increased need for antidepressant use for children and adolescents, further evaluation of the efficacy and tolerability of these psychotropics is really necessary. As documented by the literature, when evaluating antidepressant efficacy and tolerability, age must be considered because antidepressants are often prescribed off-label to young children, and the evidence for use with young children is limited. Furthermore, it is important to consider gender, as gender minorities often experience a higher rate of anxiety and depression. And moreover, we must consider race and ethnicity, as there are disparities across groups regarding the efficacy, tolerability, and rate of use of antidepressants. It is imperative that we examine differences in medication response across ethnic and racial groups, since medication metabolism may be associated with genetic ancestry. Thus, the present systematic review aimed to examine the demographic composition and diversity of samples used and reported in antidepressant efficacy and tolerability studies among children and adolescents being treated for depression and anxiety. Oops. So we conducted a systematic review of the literature from the previous 10 years. We utilized the preferred reporting items for systematic reviews and meta-analysis guidelines, or the PRISMA guidelines. The literature search was completed in September 2022 and was completed by 2 reviewers. Given the availability of medications in the extant literature, antidepressants were operationalized as sertraline, duloxetine, escitalopram, fluoxetine, and fluvoxamine. A combination of these key terms was searched within the bibliographic databases of PubMed and PsycInfo. And studies were included in the systematic review if the following criteria were met. The study examined the efficacy or tolerability of at least one antidepressant among anxiety and depression in both children and adolescent samples. The sample included children, being described as ages less than 12, and did not include adults, which was defined as greater than 19. The study also had to be originally published in English. The study had to use an original or secondary data set, and the study was conducted in the United States. The study had to be published in a peer-reviewed journal between January 2011 and September 2022. Meta-analysis, systematic reviews, protocols for future research, and case studies were excluded. The studies conducted in the US, but that also included other countries of origin, were excluded. And studies including only adolescents were also excluded. And these were the results of the articles we found. So there was a total of 124 articles that were located using the key terms in PsycInfo and PubMed. After duplicate articles were removed, the search resulted in 100 unique articles. These articles underwent an abstract review, which yielded 24 articles that underwent a full text review, which then yielded the final 11 articles that met inclusionary criteria and were included in the systematic review. These 11 articles were reviewed, and the following information was extracted from each article. We extracted the sample size, sample demographics, such as age, sex, race, ethnicity, and geographic location, disorders under evaluation, antidepressant used or that was studied, and the study design method and group differences. The current study did not require a quality review of the articles included or an assessment of risk of bias because the objective of the study was not related to the study findings. However, information concerning 2 quality indicators were extracted, effect size and whether they reported a power analysis. So after gathering all the data and reviewing those 11 articles, this is a summary of those articles that were included, starting with kind of that quality, those quality factors. 36% did not report effect sizes for their findings at all. 91% did not report a statistical power or reported any within group differences. 73% examined antidepressant use for mood disorders, and the remaining 27% examined antidepressant use in relation to anxiety. Fluoxetine, which was not a surprise, was the most common antidepressant studied. 64% of studies examined fluoxetine alone, while 1 study compared fluoxetine to other antidepressants, and 1 study studied citalopram, 1 duloxetine, and 1 sertraline. Furthermore, the study designs and methodology varied across studies. 45% had a randomized placebo-controlled design, 18% a randomized double-blind placebo-controlled design, and 18% had a retrospective cohort study design. Regarding age, participant age range from 5 to 18 years. The majority of the studies reported an average age between 11 and 14. All studies included both children, so less than 12, and adolescents. 36% of the studies did not report the distribution of the sample in relationship to child and adolescent groups. However, out of those studies that did report the distribution, 71% reported having primarily adolescent samples, and 43% reporting having approximately 80% of their sample be ages 12 and older. So again, primarily, we were looking at primarily adolescent samples. Notably, the search did not yield any studies with child-only samples. Regarding gender, all the studies included in this review reported the distribution of binary male and female sex or gender, with the overall range being 32% to 80% female. 82% of the studies reported nearly equal number of males and females, thinking of this ranging from 44% to 59% female. It is very important to note that none of the studies reported on any transgender, genderqueer, gender nonconforming demographics. We also looked at race and ethnicity that was reported for each of those studies. For the purpose of this review, studies reporting the distribution of at least 3 racial groups were considered to have fully reported racial demographics, while those reporting on only 1 to 2 races and having at least 10% of their sample unaccounted for were considered to have partially reported racial demographics. Out of the 11 studies, 1 study omitted all racial demographic information, so we weren't able to look at any details, while 64% partially reported racial demographics. Out of those that reported partial reporting, 3 studies reported both white and Black distribution of their samples. 2 reported either the percentage of Black or African American or the percentage of white Caucasian. And 1 simply described the sample as a majority white sample, did not actually provide any percentage. Only 4 studies fully reported on racial demographics. While all 4 studies reported on the white Caucasian, Black African American distribution, only a portion reported the following groups. So 3 of the 4 studies reported Asian is Asian part of the sample. 3 reported a portion of the sample as multiracial. 2 reported part of the sample being American Indian or Native American or Alaskan Native. 1 did report a portion of it as unknown or other. And notably, 1 of the studies grouped Asian and American Indian together. Therefore, there was no way for us to disaggregate that data and examine these groups separately. It is also noteworthy that all studies that reported racial demographics reporting having a majority white Caucasian sample, which is expected in the United States. Except for 1 study which only reported having 16% African American population and did not account for the remaining 84% of the sample. So once again, we do not know what that 84% looked like. Regarding ethnicity, while 64% of the studies reported what portion of the sample identified as Latino or Hispanic, 36% of the studies omitted ethnicity altogether. Among the studies that reported ethnic distribution, Latinos accounted for 0.7% to 30% of the sample. So what do we make of all of this information? What can we say about the studies of antidepressant use in children and adolescents based on the demographics that they are reporting? And before we even get into the demographics, although the quality review of the studies was not necessary for the purpose of this review, it is important to note the lack of reporting of effect sizes, and also the lack of reporting of power analyses. These omissions are very concerning as these studies were investigating group differences across those using these antidepressants versus using either other antidepressants or other therapeutic modalities. And therefore, we can't really interpret these results without having an understanding of the effect sizes and whether they had enough power. So that's, was a concerning finding. Regarding age, although all studies reported having at least some percentage of their sample be 11 years of age or younger, most studies utilize a majority adolescent sample. This is noteworthy finding because antidepressants are approved for use with younger children and are also often used off-label with young children. So we really do need to be understanding, are there any differences in how well these antidepressants are tolerated and how well they affect or therapeutic targets for younger children as well as adolescents. Regarding gender and sex, all of the reviewed studies reported the distribution of their sample based on binary terms, and no studies reported on the inclusion of transgender, genderqueer, or gender non-conforming participants. This omission is highly concerning, especially considering that as of 2017, 2% of high school students identified as transgender, 9% identified as lesbian, gay, or bisexual, and 1 in 4 LGBTQ youth identified as outside of the gender binary. Relative to cisgendered youth, transgender and gender nonconforming youth are at a higher risk for anxiety and depression, as well as suicide, which underscores the importance of including this population in the studies and investigating common treatments for these mental health difficulties. Other important findings. While most studies reported at least some portion of the race and ethnicity distribution of their sample, many only reported on limited racial groups. That is, they only reported a percentage of white participants or a percentage of Black participants. And it is important to know that one study omitted ethnic and racial demographics altogether, which was surprising, as this is usually something that is looked at when publishing an article. The racial categorizations used in some of the articles were also noteworthy for using seemingly arbitrary grouping categories, such as Asian and American Indian is one category. The studies also demonstrated bias by operationalizing racial labels, which do not appear to be representative of the groups included, such in one study using simply African rather than Black or African American groups, which were actually the ones grouped under that demographic. Also, most studies utilizing Asian as a category without differentiating between Pacific Islander is Asian or Asian American, or other notable within group differences. Additionally, 67% of the articles which reported racial demographic information had a portion of their sample unaccounted for. As evident by the results of this review, groups other than the dominant race were often grouped together as other or omitted altogether. Most of the studies did not have samples that were representative of the US population of children or of the populations that are significantly affected by the disorders treated by antidepressants. And given these exclusions, the findings from these studies may not be generalizable to the general population of children and adolescents, although they are often used as so. Although an explanation for the lack of diversity and or reporting is outside the scope of this review, it is worth noting some of the possible explanations for why these studies may not have had representative and inclusive samples. Although young children are also prescribed antidepressants, both on and off label, their lack of inclusion in studies relative to that of adolescents may be related to the lack of FDA approval for the use of this medication with really young children. And the lack of inclusion may also be related to the limited knowledge base surrounding the efficacy and tolerability of antidepressants in children, and the limited understanding of developmental effects. These limitations may prevent studies from being approved by IRB boards, and even if approved, parents may be hesitant to consent to a study using these medications on young children. Possible explanations for the underrepresentation of race and ethnic minorities include that, studies may also have might have had a difficult time recruiting people of color because they may display more hesitancy and concern regarding scientific and pharmacological studies compared to their white counterparts. This is likely related to historical discrimination and lack of equity seen in psychiatric and psychological studies in the US. Additionally, the well-documented disparities in access and utilization of healthcare are also critically important to medication use in youth from racially and culturally diverse backgrounds, as these barriers limit their access to research participation in antidepressant efficacy studies. Despite the researchers' intention to utilize non-biased sampling, their samples are representative of the populations who have the most access to care, which are often white, middle to high socioeconomic class, and English-speaking participants. The lack of racial and ethnic diversity in study samples may also be related to the same cultural factors involved in the lack of utilization of antidepressants among these populations. And some of these factors are parental perceptions, education level, cultural and religious beliefs related to medication, and also referral bias, as well as preferential use of alternative or informal services, and a decrease in health literacy. It is also important to consider the difference between the lack of representation in the studies included in this review versus the lack of or inappropriate reporting of the sample characteristics of these samples. While some studies may have successfully recruited a representative sample, we are unable to assess their sample due to the lack of reporting of demographic characteristics, or due to the biased grouping of categorical different groups. So a possible explanation for the limited, omitted, or biased reporting may be associated with the lack of consistent demographic measures used across studies. As researchers create measures and develop the methods for their studies, they may inadvertently omit categories for racial, ethnic, gender, sexuality, and other dimensions of identity. Therefore, individuals who may choose to identify as others simply did not have the ability to report their specific identity, or if they provided qualitative data, it may not have been quantified in a meaningful way. So where do we go from here? What can we do, or how can we think differently about research for antidepressant use based on these findings? So for future studies, they could benefit from addressing the current gap in the literature regarding antidepressant efficacy and tolerability across cultural groups. Studies must also strive to calculate and report statistical power and effect size in order to facilitate the interpretation and understanding of the magnitude of their findings. The current review demonstrates a lack of diversity regarding age, sex, gender, race, and ethnicity with respect to children and adolescents. A critical finding of this systematic review is that many of the studies did not report racial and ethnic demographics, and none of the studies reported the inclusion of non-binary and transgender youth. Future studies should address cultural factors that are often related to underrepresented individuals, hesitancy to engage in and or trust research in order to increase the recruitment of these groups. Additionally, community-based participatory research must be conducted to properly present this historically underrepresented and marginalized group. Future research should also include more sensitive measures of gender, race, and ethnicity to properly report the spectrum of diversity found in these samples. And also between and within group differences based on age, ethnic, racial, and gender groups. At a minimum in the United States, it is important to report age, gender, race, ethnicity, sexual orientation, disability status, immigration status, and socioeconomic status in commonly accepted terms. Furthermore, when reporting these characteristics, it's important to note if there was no representation from a certain demographic group, rather than omitting it altogether. For example, documenting that 0% of the sample was Native American, rather than not listing the category. This would allow for people reviewing and assessing the research to know who was included in this research exactly. Future studies would also benefit from resources such as the publication manual of the American Psychological Association, which the newest was published in 2020, which provides guidelines for appropriate reporting of demographic information. These guidelines urge researchers to be specific, focus on relevant characteristics, and acknowledge relevant differences. For example, when reporting age, the exact ages, or at minimum the age ranges of participants should be provided instead of broad categories such as adolescents or under 18, which were some of the way that the studies reported their the age demographic. It is also important to provide the mean and median of age groups in order to facilitate evaluating the demographics. In terms of gender and sex, it is important to use descriptors such as cisgender or assigned sex in order to capture the diversity of the sample. When reporting race and ethnicity, being a specific may mean identifying the specific nations or regions of the participants, such as Chinese American or Mexican or Dominican, compared to more generalized origins, such as Asian or Latino. While this study revealed important findings, there are also important limitations to take into consideration when interpreting these results. First, the review only extended to the last 10 years and excluded several studies conducted internationally. For example, while we were doing the review of the 120 plus articles that the search yielded, there were studies from Australia, Canada, Brazil, Germany, Mexico, and Spain. And these were all excluded. The studies that primarily assessed antidepressant use with disorders other than anxiety and depression were also excluded. And some of those that were found were those looking at autism or looking at OCD. Well, these exclusions allowed for findings relevant to the US population specifically, and to those utilizing antidepressants the most. They also limit its generalizability to international research or to research related to other mental health difficulties. The current review used two different databases, specifically PsycInfo and PubMed, and screened all peer-reviewed published articles in both of those databases. It is probable that studies were unintentionally excluded because they were not present in these two databases. Also, since these reviews only included published articles, there is a possibility of publication bias, which was not addressed via a statistical analysis. Additionally, only the data found in full text articles were assessed in the study. Therefore, future reviews could address publication bias by including not published studies such as dissertations, as well as contacting authors to gather additional demographic information that may not have been attained during the original study but was not reported, or that may have been attained during the original study. So in conclusion, despite the increased rate of antidepressants in children and adolescents, and the common practice of prescribing SSRIs and SNRIs off-label for the treatment of anxiety and depression, this review revealed a general lack of studies reporting on the efficacy and tolerability of these medications in children across the United States. Furthermore, this review revealed the lack of gender and race diversity represented in the literature regarding antidepressant use with children and adolescents. Future research is warranted to better understand and address the cultural disparities found in the utilization, efficacy, and tolerability of antidepressants in children and adolescents. And this research must include diverse samples that are representative of the populations using and needing these medications. So thank you very much for your attention. And now I just want to open the floor for questions.
Thank you so much, Elaine. This gives us so much to think about from a clinical standpoint and from a public health and policy standpoint. I'm curious if in the literature review, you came across also what types of providers are prescribing medications to, or tend to be prescribing medications to underrepresented or marginalized groups. And this comes from kind of more an anecdotal thought of mine that, you know, if more marginalized groups of individuals have like limited access to care, they may be more likely to be prescribed something like an antidepressant from something like a primary care provider, versus a psychiatrist or a psych NP, for example. It's more of kind of a curiosity of mine where there's this intersection of clinical and meaningful information with policy and equity. Did you come across that at all? And
Yeah. So, and I realized I didn't go too much into it, but part of kind of this really gap in treatment of psychiatric disorders in children is that the demand is much greater than what can be, met by psychiatrists. So there is a large portion of individuals getting prescriptions through their primary care physician, especially because many of these underrepresented groups do not have access due to like health insurance or even just having access to a psychiatrist in their location. So a lot of times it does come from a primary care physician. Yeah.
very interesting. It's reminding me of the PK study that's being run right now. It's for a topic for another time, but interesting nonetheless. Another question that we have here is, notice that 91% of the studies did not report power or within group differences. From your perspective, why is that so important to report power analysis with this particular topic?
Yeah, for sure. So, again, most of these are looking at, comparing, right, the groups that are getting the SSRI or SNRI versus a group that is getting some other type of treatment or not getting treatment at all. And so when we are thinking about, comparing these groups, it's important to have enough power to be able to make sure that that we have enough power to be able to find those results. And this is even more important for when we want to look at group differences across gender or across race and ethnicity. Because what I notice from a lot of the research is that they simply say, oh, we didn't find any group differences. But if you look at the samples, a lot of times they weren't really big enough to be able to find significant findings. They needed kind of larger groups, which is why it's so important to really, I think, be intentional about recruiting larger groups of, Black Americans, Latino Americans, making sure that you have enough like male, female in your group, because as many of you know, there is a larger, I think, usually female population doing research lately. So again, it just limits the ability for us to really find significant differences. And so that also kind of begs the question of like, okay, many of these studies that say there's no group differences, like, is there truly no group differences, or did we just not have enough power to find that? And so those differences are just masked.
Mm-hmm. Yeah, it makes a lot of sense. I'm wondering too what you think about how researchers can do a better job at recruiting diverse samples that we need.
Yeah, for sure. I think it really does start from like the beginning, I guess, of research and recruiting and training diverse researchers. I think, bringing those different perspectives can help inform the study development from the get-go, and help reach populations that may believe, that may be hesitant to engage in research. Because I think, in the worldwide, but especially in the United States, we do have a dark history with, the maltreatment of diverse populations through research, right, and through psychiatry and psychology history. So I think it's important to kind of bridge that and heal that by, I think, representation, like having those groups represented in the people who are creating this research. I also think, like, just even knowing this, that there are true differences, like biological, physiological differences that might be related to genetic ancestry, and knowing that it is important to have these groups represented. So like from the get-go, you are thinking of, okay, we need a certain percentage of these different groups so that we can look at these differences. So kind of having that in mind as you are kind of recruiting from the beginning, rather than kind of at the end. A lot of people are like, oh, look, we have 80% white participants. Maybe we need to do something about that. And then I think the last thing, which I kind of briefly touched on, is just, I think it's really important to use community participatory research methods, because really working alongside community organizations that serve those diverse groups are going to be the best way to recruit those participants, because that kind of increases the trust in that community.
Thank you. Got another question here. Thanks for your great talk, Elaine. What do you think would happen if you expanded the search criteria to include studies not conducted in the US?
Yeah, I think that's a great question. And I think that thinking about the countries that were like represented in the search, but that we didn't include, like Australia or Spain, I think that they probably have similar issues like we do here in America. Like I imagine that work in Australia doesn't include like native or Aboriginal kind of cultures in a lot of their studies. So I do think broadly, across the world, there is a lack of representation of minority groups. But I do think, of course, it wouldn't have been, like the findings wouldn't have been as relevant to the US population specifically.
I'm also thinking in terms of like idioms of distress and, sort of how anxiety and depression are expressed in diverse cultures might be something to kind of keep in mind as well.
Yeah, for sure.
The last question here is, why did you exclude studies with only adolescent samples?
Yeah, that's a great question, which we also got from the reviewers when we published it. But when we were originally wanting to do the systematic review, we really just wanted to look at children, because the adolescent literature is much more robust, and we do know more of how these antidepressants work with adolescents specifically, but truly we don't know so much about like young children. And so we tried to find just studies looking at like 12 and under, and we actually didn't find any in the last decade. So because of that, then we added the adolescents. But again, we didn't want to just look at adolescent studies, because I think that was going to muddy the waters on what these studies look like that include young children. So we kind of just looked at those that had both young children and adolescents. And like I noted, the findings were that even those including young children, they were primarily still adolescents, right? Like a lot of them were like 80% 12 and older. But as we all know, working here at UCLA, we get a lot of young children who are on antidepressants, who are 6, 7, 8. And these kids are not being, and these ages aren't being as represented in the studies.
Fantastic. All right. I think that was our last question. Thank you so much for presenting today. If anybody has questions, is it all right if they reach out to you directly?
Yeah, for sure. I'm happy to answer any questions or share any of the results as well.
Perfect. All right. Thanks so much, Elaine. All right. Take care, everybody.
Thank you, everyone.